If we could go ahead and get started and just everybody find your seat. We're going to start our Pathway for Enhanced Recovery in Bariatric Surgery. This is going to be a combination symposium between three societies. This hasn't been done before. It includes both IFSO as well as the ERAS Society as well as ISCOP. I'm chairing the session. I'm Dr. John Morton from the United States, and my co-chair is Dr. Anu Wadpa, who's chairing from IPSCOP, which is the International Society devoted towards anesthesia in the obese patient. And you're going to hear from an all-star panel today, and I'm going to go ahead and get it started. So I'm going to talk about preoperative rehab, how to prepare the patient, and then we're going to hear from a few other folks in the course of today's session. So as you can see here, I'll talk a little bit about prehab, how we can prepare the patient before surgery, and the role that, that pre-op surgery weight loss can play. So as you can see here in the United States, there's been a big shift currently in terms of the number of cases that we've done and also the types. The types of surgery in the US at least have become predominantly sleeve, as you can see in this slide. We're now doing over 250,000 cases with the updated numbers, and the vast majority are the sleeve. Now, the one thing that we do know is that the sleeve is a good operation in the right hands and in the right patients, but the one thing that we do know about the sleeve is that the weight loss is perhaps less than what we see with the bypass. So what are ways that we can enhance some of the outcomes for the sleeve? Perhaps by enhancing the weight loss prior to surgery might make a difference for it. So this is some of the results we've seen in the US around what's happened with mortality rates, how it's declined. And I think one of the reasons that we've seen that decline in mortality in the US has been that we have accreditation, which gives us a platform to do prehabilitation, and also the choice of procedures changed in fellowship training. These are the most recent results in the US around where we are with mortality rates, roughly about 1 out of 1,000. One thing that we do know is that accredited centers do matter, and I know that varies from around the world, but if you take a look at the US, accredited centers certainly make a difference when it comes to charges, cost, complication, and even mortality. Now, this has been recognized by all the payers in the United States, so in order to get paid, you must have accreditation. And that's how it works in the US, and the reason they do it is because they see benefit. They see the benefit in that these accreditation programs give people an opportunity for quality improvement where you can make a difference in preparing your patient. So one of the programs that we've initiated in the US is called Strong for Surgery. And the idea is that surgery is a big event, almost like a race. If you're going to run a race, you want to prepare for that race by training. And one of the ways that we can help prepare for surgery is by early ambulation, making sure that patients get the optimal nutrition. And that means for obese patients as well. To be obese is not to be optimized nutritionally. You've got to get your weight down in order to improve your outcome. The other thing to take note of is even if you're obese, there can be nutritional deficiencies. You can have a lot of calories, but not a lot of nutrition. And as a result, sometimes vitamins can play a role too. The other thing that can make a big difference is smoking cessation, blood pressure, glycemic control, medication reconciliation. The good news is that across the board for all of these elements for Strong for Surgery is that weight loss can play a big role. Now I'm going to share with you some of the plans that we've had in the US around enhancing people prior to surgery, and that's our program called Energy that we just completed and will be coming out for publication in SWORD in the next couple of months. And this was an enhanced recovery program, and we did it for roughly about 38 hospitals in the US. I think many in the audience are familiar with what are the components for ERAS. Again, it's preparing patients for a big event, and that is surgery, making sure that they're getting the right kind of pain, fluid management, and glycemic management. As you can see here, these were the number of centers that were involved in the Energy study, and as I mentioned before, about 37 altogether. Here are the elements for the ERAS protocol in the US called Energy. It was divided into pre-op, intra-op, and post-op. Preoperatively, like many of these ERAS programs, it involves education, carb loading, making sure you're getting the liquids, and of course, preemptive analgesia. One thing that you should know is that the number of pain receptors we have, nociceptors, is dynamic, meaning that they can rise and fall based on stimuli. So if you blunt that response from the very beginning, you're not going to have as much pain afterwards. Intraoperatively, you can see some of the things that we're trying to do is avoid those opiates. Doing a lot of regional anesthesia was important, and of course controlling blood sugar and fluids. The other elements of the protocol included making sure patients were up and walking, avoidance of drains, and of course avoidance of opiates. We also had some patient-reported outcomes. Here's some of the results, and you can see here we had 26 different processes, and based on adherence to those processes, we decreased the lengths of stay that were extended across the board with more adherence. The other thing I want to point out, this is a problem more in the U.S. than it is internationally, but it is a problem, and that's the use of opiates in the U.S. We've had several thousand people die from opiate overdoses, and in the U.S., about 1 out of 7 patients after bariatric surgery are still taking opiates, and it's something that we want to stop. We did a study a few years ago where we quantified if we were able to completely eliminate blood clots and leaks, we would reduce mortalities in the U.S. by 48 deaths. If we're able to reduce opiate use at 1 year by 50%, we'll actually have more impact on mortality by making sure people are not taking opiates, becoming dependent, and overdosing. So this is a new program that we're starting next month in the United States. Here's another way that certainly we can optimize our patients is smoking cessation. We're all doctors. We want to make sure that people are getting their very best health. And the other thing that we want to do is demonstrate that these outcomes can have impact. Opiate detoxification, as I mentioned to you before, is a goal for us. We want to make sure that patients are not taking this unless absolutely necessary, and it can certainly have an impact at the end of the day when it comes to outcomes. Glycemic control, we all know that if we keep blood sugar control under 6 or 6.5 for hemoglobin A1C, we're going to have much better outcomes, and that's what was demonstrated in this study. Proton pump inhibition is another process that we can add, and it does seem to perhaps, at least in the gastric bypass, reduce risk of stomal ulceration. H. pylori eradication is well known across the field of medicine where it can make a difference not only for ulcer formation but perhaps in other areas of GI upset. So eradicating H. pylori can make a difference. Actigol can also play a role in helping reduce the risk of gallstones afterwards because of the use of the bile salts. There's also a little bit of evidence that it may influence the microbiome changes that we see after bariatric surgery in the positive. It's pretty easy for people to take, and it can have some benefit. VT prophylaxis, we don't have a lot of different recommendations that are approved as class 1. The one thing we do recommend is that you do something because there is a risk for patients having blood clots. The biggest risk occurs when they're on the table and anesthesia is induced. That's when the blood clot forms. So it is important to try to use some sort of heparin prior to surgery, and of course getting patients up and walking around. So these are the current recommendations, as I mentioned to you before, probably low molecular weight. Heparin is just as efficacious, and it's a lot cheaper than the longer acting. And filters have not been utilized on a wide basis. Now the other part where we can certainly make a big difference around glycemic control, blood pressure control, ambulation, complications, is making sure the patients perhaps lose weight before surgery. There is a pretty good association behind people losing weight and decreasing the risk of complications. There is also evidence that if you lose some weight before surgery, you'll lose more weight afterwards. And this is a study that was done a few years ago that demonstrated exactly that. Now let's imagine, if we will, taking a page from our cancer colleagues where they use chemotherapy prior to operating on a tumor. They can shrink that tumor, have a better result. Perhaps the same thing can happen with us. If we shrink the patient, maybe we'll have some better results for them as well. And there are a lot of different examples of this in medicine, everything from breast cancer to heart disease to even colorectal surgery. Using combination therapy enhances results. So it's something that we can look at for the future. Now, if we look at the lab study, this is looking at the average weight loss. Looks tremendous, especially at 7 years. But if we take a closer look, there's more variation than we imagine. And that variation is something that we need to address so everybody has an optimal outcome and there are less people that need revisions. This is a study that we just finished last year based on about 3,500 patients, and what we found was that the variation was the least for the bypass and the most for the band, which is not done much anymore, but the sleeve in the middle had a great degree of variation. Just to remind you, this is the operation that we do the most in the United States, so we need to do something to prevent that variation in outcome. And of course, there's always opportunities for revisions, and this is a paper that we published a few years ago about reoperative bariatric surgery. And the one thing we do know that overall is pretty safe, but if you compare it to primary surgery, there is more risk of complication and less weight loss. So why do something if you don't have to? Maybe we can prevent revisions by addressing the problem up front prior to the primary surgery. And if we look at this study from a couple of years ago, it demonstrated that the ability to get to a normal BMI or released overweight BMI is going to be very difficult if your starting BMI is above 50. So we need to see what else we can do. As I mentioned to you before, weight loss is something that can happen before surgery. The evidence is pretty clear with meta-analyses that it does work. And as I mentioned to you before, if you gain weight before surgery, you're going to increase your risk of complication. So making sure that patients are losing weight before surgery is important, particularly for the larger patients. Here you can see a study that we just completed where it is something that's feasible. We use low-dose phentermine, and as you can see on the next slide, when people were on the drug, very few of them gained weight, as opposed to the patients who were not on drug. They gained 40% of the time. So it's an opportunity for us to enhance our results. Again, GLP-1 is a hormone that we know in bariatric surgery, and there are GLP-1 agonists out there that can also help us lose weight, and that's something that's available too. Now, the few studies that have been out there have been primarily for using it after surgery, which I think is probably too late. The time is to use it before surgery so we can enhance those results. This is looking at when we know the ultimate outcome in terms of weight loss for our patients. We can actually know pretty early on at 6 months who's going to need to lose more weight than others. So this is an ideal opportunity, if you will, to add medication. Take again a page from our oncology colleagues. When they did a lumpectomy, they added tamoxifen afterwards to make sure that the results they had were enduring and that they continued to be good. So it's something that we perhaps should look at in a randomized trial, and it'll be multi-center. The other place I wanted to point out is that weight loss before surgery has advantage not only for bariatric surgery, but has advantages for other types of surgery. For example, transplant. You can't be listed for an organ transplant if your BMI is over 35. If you're going to fix a hernia, it makes sense to fix that hernia when the patient's BMI is lower. And another example is joint replacement. This is a very common operation across the world, and in the U.S., there's about 1 million done a year. And we've started a program in the United States where we cooperate with the American Hip and Knee Society, the orthopedic surgeons, and we've done position statements together. We've presented at their meeting, they've presented at our meeting, and we're actually doing a trial together. This is one of those, one of the programs that we've had is this position statement that we came out together where we see that the outcomes for people with joint replacement who are obese are worse. So why not decrease that weight, control the blood sugar, control the blood pressure, have a better outcome for those patients. This is the SWIFT trial that we're doing, which is surgical weight loss, to see if we can influence joint replacement outcomes. And it's just getting underway in the U.S. We hope to have results next year for you. But this is a great opportunity, regardless of the country you're in, to partner with your orthopedic surgeons to improve those outcomes. And this is what the study will look like. We'll look at everything from mobility to patient satisfaction, so a lot of functional measurement as well. So there is a case to be made that prior to surgery, if we can decrease weight, we can hopefully improve outcomes and safeguard those results. This is my institution, Yale, which was founded in 1701, which makes it older than the United States. Thank you very much. Our next speaker is going to be Dr. Farouk Baldwin, who's going to be talking to us from the MENAC chapter from UAE, and he's going to be talking about optimization of NPO and carbohydrate loading. And please join me in welcoming our speaker.
Okay. The multiple modalities which make up enhanced recovery protocols. Among those, there are about preoperative hydration and carbohydrate loading. This is the topic I'm going to be focusing on. Right. It's avoiding that light. How many of surgeons or anesthetists here actually allow their patients to drink 2 hours before surgery? Oh, that's good. That's a lot of you. I think these guidelines have been around. And how many would you allow solids 6 hours before surgery? About 50%? No. And who amongst us uses the carbohydrate loading routinely? Much lesser, maybe 25%. Right. Just shows, the history of preoperative fasting goes back to the time when I think the obstetricians decided that women who had a meal much earlier than 8 hours actually had a problem. So there's been a thing which is stuck with us that overnight fasting before surgery is essential. And this is still practiced in many places. And it is 8 hours of absolute fasting, still considered fundamental by many anesthesiologists and surgeons, and the reason being a concern that a shorter period of fasting puts the patient at a risk of regurgitation or aspiration. However, clinical evidence for over 20 years and more has established that a shortened preoperative fast does not increase the risk of regurgitation or the aspiration. So the new fasting guidelines, therefore, came out in 1999, which was a pretty good recommendations. The shortened preoperative fasting and oral rehydration 2 hours before surgery has been in place since 1999. But then there wasn't the change coming in, and again, old habits die hard. This been what is fixed in the mind is hard to change. So about 18 years later, the ASA again renewed the fasting guidelines and to reinforce the message. And it's been pretty well established that clear fluid should be allowed until about 2 hours before surgery, which includes not just water, but fruit juices, carbonated beverages, clear tea, and black coffee. And solids up to 6 hours before surgery, excluding those which are maybe too fatty or which contain meat, which really should be properly addressed at 8 hours. Oral hydration 2 hours before surgery makes the patient less thirsty, less anxious, increases postoperative strength compared to NPO of 6 to 8 hours, and it does not in any way increase the risk of pulmonary aspiration compared to NPO after midnight. So is there any difference between normal and the obese patient? Is there a problem? I mean, we consider possibly diabetes, diabetic gastropathy, all of these things could be there. So there isn't a lot of evidence to prove that there is any difference. There is one small study from Japan which seems to support the fact that there doesn't seem to be much difference in gastric emptying between normal and bariatric patients for a ORS solution. There probably isn't much difference in gastric emptying after ORS injection in the two different groups. Carbohydrate loading, why, when, and how? There is a degree of insulin resistance that develops after surgery. It happens after all surgical procedure, however minor or major. And the degree of surgical trauma or the length of surgery or the magnitude of surgery could actually make this, it's directly proportional to that. So insulin resistance induces hyperglycemia, which in turn increases the risk of multiple complications. Preoperative carbohydrate loading reduces postoperative insulin resistance. This has been published since 2001. And if the effect of preoperative carbohydrate loading on stress response is to reduce it improves patients' well-being, muscle function, minimizes protein loss, and does not increase the risk of pulmonary aspiration in any way, and certainly reducing the stress response. And the rationale for carb loading in the context of IRAS, its benefits is generally to improve patient comfort or well-being, but with the objective parameters of reducing the insulin resistance. So in patient which is fed and is metabolically prepared to withstand the ensuing physiological change of surgery, these include a reduction in insulin resistance by up to 50% for a range of major surgeries. So obviously the benefits are proven. The practice is something that we probably have to look at actually adding into the practice of our surgery. Again, the systematic review on carbohydrate loading proves the intake of high carbohydrate liquids 2 hours before surgery improves insulin-resistant patient well-being and reduces hunger, thirst, nausea, anxiety, and enhances postoperative muscle and bowel function. How do we do that? What are the recommendations? I mean, I was looking at it and I found this paper or an internal document, the clinical guidance in the British Columbia Enhanced Recovery Collaborative seems to actually give the most detailed description of how this should be carried out. Generally recommended is 800 ml of 100 grams of complex carbohydrate is what's to be given 8 to 12 hours pre-op, and then another 50 grams taken 2 to 3 hours pre-op is what's the recommended dose of the carbohydrates. And looking at the ease of administration and the process of administration, various different parameters that you might want to examine how we're doing that. There are several proprietary preparations that are available, pre-op, preload, very many. I mean, but the main thing is that they must be complex carbohydrates and they must have a osmolality of less than 295 milliosmoles per kilogram, because that's the part that has been studied. So what carbohydrate is suitable? Most popular preparations are drinks that contain maltodextrin that empty readily. What about diabetes? What's carbohydrate? Do we worry about giving all this carbohydrate for diabetes? Obviously, it doesn't make a difference. This paper from 2008 from the leaders in the art of IRAS seems to suggest that that's not a problem with paracetamol, and it did not in any way have any issue with gastric emptying. There was no sign of delayed gastric emptying, suggesting that a carbohydrate-rich drink may be safely administered 120 minutes before anesthesia without risk of hyperglycemia or aspiration. So the safety and advantages of continued nutrition and hydration as close to surgery as possible are now fully established. Preoperative fasting, 2 hours for clear liquids and 6 hours for non-fat solids should be the standard of care. Carbohydrate mechanisms of reduction in the insulin resistance and thereby the surgical stress through carbohydrate loading have been studied and established. So in conclusion, shorter fasting times and a well-hydrated and well-fed patient is equal to stress reduction, a happier patient, faster recovery, and less complications. So if you're not already doing it, it's time to start doing so. Thank you.
Well, I want to thank Farouk for that excellent presentation, and we're going to take some questions and discussion at the end. I think he's pointed out the utility in making sure that patients are adequately hydrated and loaded before surgery, and there's a lot of change that needs to occur, and we welcome his leadership in that change. Our next discussant is coming to us from Brazil, and that's Dr. Juliana Franzotti, and she's going to talk to us about pulmonary preoperative preparation. So welcome. Either one.
Good afternoon. Thanks for the invitation. I'm a physical therapist, and I will start with the short background about respiratory mechanics and obesity. So, increase in fat around the thorax impair diaphragmatic function and reduce compliance of thorax and lungs. Consequence, leading to an increase in respiratory muscle work. Low compliance of respiratory system equal 1/3 of normal, and there are increasing total oxygen consumption by obese people. So, mechanical disadvantage with the hypercapnia respiratory failure and the more probability to obstructive sleep apnea and asthma. So, the most important part of evaluation is identify predictors of respiratory complication. First of all, type of obesity. Central abdominal obesity has greater impact on spirometric measures. About metabolic syndrome is an independent risk factor for worsening respiratory symptoms. And the BMI over 47 kilos per square meter is associated to respiratory complication because the BMI is inversely proportional to lung function. About smoking history, tobacco smoking is associated with increased risk of postoperative morbidity and mortality, mainly to reduce tissue oxygen, pulmonary complications, and thromboembolism. So, low oxygen saturation in the preoperative period is correlated with the post-operative complication. And the low respiratory pressures due to the respiratory muscle weakness or muscle dysfunction in the preoperative period may delay the expected recovery period, favoring the onset of postoperative respiratory complication. About X-ray is important for all patients, but pulmonary function testing is essential to elderly patients, patients with chronic pulmonary disease, and current smokers. Stop bang questionnaire is a way to diagnose obstructive sleep apnea. It is very easy to use with the positive and negative answers that show high or low risk of obstructive sleep apnea. This questionnaire is also important because the OSA is a positive predictor to difficult intubation. Polysonography is a gold standard exam to diagnose obstructive sleep apnea. It's important in the preoperative period because the OSA is a potentially life-threatening condition when not detected and managed appropriately. So, physical therapy intervention. Improve pulmonary volumes and capacities, optimize gas exchanges, and improve thoraco-abdominal mobility with all breathing exercises. To eradicate OSA, CPAP therapy is recommended to reduce the risk of perioperative complications. The ideal is in preoperative period, apnea patients have to start the treatment in the preoperative period and continue until 1 month after the procedure, the ideal. Inspiratory muscle training is a physical therapy resource to improve the power and the strength of respiratory muscles. Nowadays, guidelines for perioperative care in bariatric surgery recommended smoke cessation at least 4 weeks before the procedure. And the locomotor rehabilitation system is an important part of the whole process because the early ambulation is essential to a good and a fast recovery in the postoperative period. mainly to atelectasis reversal and thromboprophylaxis. Encouragement to practice physical activity, and now I would like to show a small part of the preliminary results by my own study, prospective and observational study, convenience sample, the same team, anesthetic, multidisciplinary, and nursing team, in minimal invasive surgery hospital. All patients were submitted to video laparoscopy and gastric bypass. And my sample, N equal 100, 84% women, 16% men, average BMI 42 kilos per square meter, and the average age 37 years old. Two groups were observed. The first one, physical therapy group, with the physical therapy in the preoperative period. And the second group, the control group without physical therapy in the preoperative period. But in the postoperative period, I attended all patients. So, results. About oxygen saturation in the first session, the physical therapy group had a better oxygenation, up 4%. This is a clinical and a statistical difference. And regarding oxygen therapy, the physical therapy group, we didn't use oxygen. However, the control group used around 15%. Regarding CPAP therapy since preoperative period to eradicate obstructive sleep apnea, only physical therapy group used around 25%. And about length hospital stay, the physical therapy group stayed at the hospital 28.2 hours, and the other hand, the control group stayed almost 46 hours. So the physical therapy group had better oxygenation. They didn't require oxygen supplementation, and they stayed in hospital 1 day less than the control group. So the ERAS is important for patient recovery, and the inclusion of physiotherapists in ERAS team highlights the importance of physiotherapists in the patient treatment before and after the procedure. I have been working at Gastro-Bezo Center almost 15 years, and the surgical team, thanks God, appreciate my work and prescribe for all patients physiotherapy since the preoperative period. Our team is complete, and I would like to thank you for this opportunity and for your attention.
Obrigado for that wonderful presentation. It shows that enhanced recovery is truly a team sport, and we need to get everybody involved. So those are some great results. We're next going to hear about how to decrease surgical-related inflammation from Juan Pujol. He's coming to us from Spain, and we look forward to his talk because we know that obesity is truly a disease of inflammation, so I'm looking forward to his talk. Thank you.
Thank you. Okay, I like moving. So thank you very much. Let me thank Antonio Torres for giving me the lovely opportunity of being here with all of you. Now, when Antonio asked me, well, you have to talk about how to lower the surgical inflammation, I thought, well, the best way is not to operate. But as we have to do it, let's begin the talk. Well, in 1932, Cannon defined the word homeostasis, and it was defined as the coordinated physiological processes which maintain most of the steady states in the organism. In fact, homeostasis should be seen as a delicate dynamic equilibrium that can be broken by any external aggression. And obviously, surgery is a physical aggression. Every injury we make when we are operating induces a patient's body response in order to restore the original state. This process is known as inflammation. In fact, the surgical incision induces local damage to tissue, nerves, terminal nerves, pain receptors, blood vessels, and this leads to afferent signals from the injury site to the brain and stimulates the neural, hormonal, and immune system. The local damage leads to ischemia, edema, immune response, metabolic dysfunction, and all these factors contribute to a succession of rapidly cascading events from local to systemic phenomenon that can stress our patient, and hence we call it the stress response. And to a certain extent, a moderate stress is advantageous for our patient, but an excessive stress can be a problem. The system can quickly overshoot and become a potentially harmful outcome, such as cardiovascular dysfunction, coagulopathy, inflammation, or even immunosuppression. So any attempt to attenuate the inflammatory response could lead to a faster recovery and minimizes the impact of the treatment. And as surgeons, the best way of doing it, I've already said it, is to do less harm. We should focus all our effort into avoiding any unnecessary tissue damage. And you would say, well, I do it in every operation, and you're right. In fact, throughout the history of surgery, we've had a constant evolution. There has been a constant evolution towards an improving perioperative medicine, better infection control, but above all, an incredible technical evolution that allowed us today to perform our operations with far less aggression than before. So what I'm going to list here now is these important, some of these important perioperative steps that makes our operation much better and less aggressive. So let's go on. Number one, be well prepared and well trained. Surgery begins long before the first incision. A good surgical training is the base for a future good operation. So reduction in morbidity and mortality has been shown to occur as a function of surgical experience. Be well prepared, be well trained. That's what IFSO guidelines recommend. The surgeon has to have the optimal theoretical knowledge and the necessary technical skills. It's quite obvious. Number two, ask for help. As you know, bariatric surgery is a teamwork. It's a multidisciplinary science. It's a team commitment. So involve all your colleagues as much as you can. Physicians, anesthesiologists, psychologists, endocrinologists, nurses, dietitians, physical therapists, they are all welcome for the good of our patient. Number three, which is the most important part of the team? The patient. So involve your patient. You know that bariatric patients are high-risk patients full of comorbidity. And an preoperative improvement of our patient's physiological status results in an improved postoperative course and less complications. Take your patient, involve them, make them feel part of the team. Make your patient lose weight. Plan a correct feeding program before surgery. Encourage your patient to stop smoking and drinking alcohol and control their comorbidities before surgery. Number four, now we are in the OR. During the operations, the less invasive, the better. The surgical stress originates an immune, hormonal, and metabolic dysfunction that is directly proportional to the extent of the surgical trauma. So let's be delicate. Here it's been well demonstrated that inflammatory mediators such as interleukin-6 levels, correlate well with the length of the surgical incision. With the larger the incision, the higher the inflammation markers. So we have to be delicate. And regarding this, it's been well demonstrated that with laparoscopic or minimally invasive surgery, the tissue damage is much less than in open surgery. With laparoscopic surgery, there has been a proven significant decrease in inflammatory markers such as C-reactive protein, leukocytes, interleukin-6 levels, and other cytokines. In fact, laparoscopic surgery has demonstrated to reduce the hospital stay, the incisional hernia, blood loss, postoperative pain. They are all stress factors and hence leads to an early recovery. Number 5, avoid complications. That's quite obvious, isn't it? Yeah, but be consciously delicate. There's no need to hurry. Here again, inflammatory marker has been demonstrated to be proportional to the extent of the tissue injury more than the duration of the procedure. So take your time if you need it, but be delicate and try to avoid any unnecessary tissue damage, any complications. Avoid bleeding. Bleed leads to ischemia, so control bleeding and correct intravascular volume. In fact, tissue needs oxygen to accomplish a correct, a complete healing process. Prevent infections. We have to prevent infections by using prophylactic antibiotic, avoiding gut ischemia. Again, be delicate, try and avoid bleeding, be accurate with anastomosis. This is quite obvious, but it's what we have to do. Failure of the intestinal barrier by, for example, an anastomotic leak has an important etiological factor of sepsis and multiple organ failure. Avoid deep vein thrombosis. Avoid thromboembolism pulmonary. Pulmonary thromboembolism. This is the second cause of death in bariatric surgery. We have to do everything in our power to avoid them. So use mechanical methods and should be combined with pharmacological prophylaxis with low molecular weight heparin. Be active preventing hypothermia of your patients by heating the patients with forced air blankets and intravenous fluids. It will attenuate the stress of the operation, has demonstrated to lower the complication rate, reduces the risk of wound infection, and improves the outcome of our patients. So keep your patients warm. Avoid any unnecessary stress factor. Decrease systematic use of urinary catheter. Don't use it if your operation is planned to be short. Remove nasogastric tube before reversal of anesthesia. It's a pain for the patient. It's a stress factor. It has not demonstrated any advantage in preventing leaks, and it can favor pulmonary infections. Keep drains the shortest possible time. Again, it's a foreign body. It's a pain for the patient, and it can limit the breathing. Don't make the patient suffer unnecessary nauseas, vomiting, or pain, as it could be a stress factor leading to an increased inflammatory response. So use multimodal systemic analgesia, use local anesthetic infiltration techniques, and combine different antiemetic drugs. Make your patient feel comfortable when they are in hospital. Encourage early patient mobilization. This not only prevents deep vein thrombosis, but also facilitates breathing and faster functional recovery. Keep your patient in a positive atmosphere. Take care of their respiratory function, serum glucose levels, blood pressure, and other concomitant physiological parameters. Encourage early enteral feeding. Is the physiological way of doing, and it will improve the autonomy of our patients. And to finish my talk, discharge the patient as soon as they are ready. They will be much better in their home than in the hospital. Well, this talk has been supported by many scientific evidence, but obviously we do not have time to mention them, so I will be very pleased to put them in my website for those who want any extra data. Thank you very much for your attention.
Bueno, muchas gracias por esa plática tan excelente. We really appreciate that talk. It was a terrific overview. The graphics were outstanding. That was extremely well done. Our next talk will be on a very specific subject, which is on the concept of peritoneal inflammation. From Poland, we have Dr. Tomasz Gazinski, who's going to be presenting this talk today. So please join me in welcoming Dr. Gazinski.
Dear Chairman, ladies and gentlemen, first of all, I'd like to thank you very much for inviting me for this very nice meeting. Well, I'm an anesthesiologist, so the question that I asked myself when I prepared this presentation was, should I talk to surgeons how to treat peritonitis? It would be like, you know, man talks to the woman how to give birth. Well, but I tried to tell you something interesting that may influence how to avoid some problems with inflammation during the surgery. So, first of all, it's obesity is connected with constant low-level inflammation, which can be observed, for example, in lab tests when you test the level of C-reacted protein. It is related to metabolic and humoral activity of excess fat tissue, but it has not a very important influence on patient condition unless you start a surgery. It may be difficult to recognize in obese patients peritoneal inflammation because of diagnostic problems, and this you know, of course, that it is described that persistent, for example, tachycardia after bariatric surgery should be investigated for peritoneal inflammation. Laparoscopic bariatric surgery in obese patients usually is associated with increased level of pneumoperitoneum pressure because of decreased abdominal wall compliance. And in those patients, we already observe increased intra-abdominal pressure because of the amount of the fat tissue in the abdomen. And high pneumoperitoneum pressure may create some peritoneal subinflammation status because of temporary ischemia. And this what I would like to talk now is that anesthesia may influence this, how to the outcome of the patient after the surgery. Because the anesthesia, in fact, nowadays, you can say, is not only putting the patient to sleep, but it has influence on the outcome of the patient. How we anesthetize the patient, we influence the outcome. So when I prepared the talk, I came across of this article. It was published 69 years ago. 69 years ago, the authors of this article pointed on the concept of so-called tight belly. So the patient who is not well anesthetized regarding the muscle relaxation. And 69 years ago, the authors said that the obese patients are especially those patients who require good muscle relaxation to avoid complications. So the tight abdomen, this concept of the not well relaxed patient is one of the factors influencing adverse events, including the risk of shock, raises of mortality and morbidity, hemorrhage, etc., etc. So we anesthesiologists can help the surgeons to avoid complications, which is very important. So change from moderate to deep neuromuscular blockade not only improve surgical conditions, but also prevent from some major complications. So we are the part of the team, and we can influence the outpatient outcome, what is very important in this case. So there are some works showing that working space is very important. This, what was mentioned in the lecture before, that if you want to do the operation very smoothly, very nice, without excessive tissue damage, you need good conditions. So the patient who is well relaxed under deep neuromuscular blockade usually is easier to operate, so it's prevention of complications. And another work published also lately, deep neuromuscular block not only improves surgical conditions, but also decreases number of complications and decreases post-operative pain. That's what also was mentioned, the use and overuse of opioids in post-operative period. This, if we can, this what we do during the operation, during the anesthesia, can influence post-operative course of this patient, including, for example, the reduced use of opioids. So, however, there are some other works showing that in deep neuromuscular blockade is very good. However, not in every patient we can have the same results because some patients, especially obese patients, may be quite reluctant to deep neuromuscular blockade because of type of obesity. So the patients who are so-called apple-shaped obesity, abdominal obesity, may be difficult to achieve good space condition, this workspace, even in deep neuromuscular blockade. However, we should try to do it to increase the surgical conditions and to prevent complications. As I said just a moment ago, the anesthesia is not just putting the patient to sleep. The anesthesia can influence the patient outcome because the modern concept of anesthesia also includes the influence of anesthetics or anesthetic technique on immune system. And it's widely, because the obese patients have those chronic, low-grade systemic inflammation, the type of anesthetics we use and the technique of anesthesia we provide can influence the patient outcome because nowadays we have the very good evidence-based medicine on influence of anesthetics on an immune system. Some of them can be immunosuppressive, some of them can, on the reverse, on the contrary, they can stimulate immune system. So some of anesthetics can be anti-inflammatory, and some of them can even promote inflammation after surgery. So, as I said, nowadays we have some very nice evidence-based medicine about anti-inflammatory properties of anesthetic agents, and we can choose the best method of anesthesia our patient to prevent some adverse events, including a strong inflammatory reaction after the operation. There are some studies going on, and we will have new data in next years showing, for example, the advantages or disadvantages of some techniques, for example, inhalation anesthesia versus total intravenous anesthesia. This is what we already know, that in, for example, cancer patient, it's better to do total intravenous anesthesia instead of inhalation anesthesia because the propofol total intravenous anesthesia has very good immune modulation effect and can produce the effect that can prevent from reoccurrence of cancer in those patients. So Also, opioid-free anesthesia is a very good concept because we know that excessive use of opioids in perioperative period can be immunosuppressive, so can promote inflammation and can be also can influence the outcome of the patients. So we now have some drugs, we have some anesthetic techniques that can prevent from excessive inflammation reaction. Of course, obese patients also can be quite reluctant to excessive inflammation reaction, which was described as obesity paradox in ICU. There are some works that are also trying to explain this phenomena. However, luckily for us, not every patient, a small number of the bariatric patients have sepsis. So, in fact, we should talk not about like this, that in the near future, the palliative care of the obese patient may also be guided by different anesthetic strategies with careful regard to immune status of the patient. And although still we have to wait for good data on influence of anesthetics on immune system, in the future probably we will talk about how to prevent from excessive immune suppression, for example, after the operation, by choosing good anesthesia technique. Thank you very much.
Thank you very much. Our next speaker is also an anesthesiologist coming from Brazil, and it's Dr. Luis Falcao, and he's going to talk to us about the absolutely critical and essential role that the anesthesiologist plays in enhanced recovery for our patients. So please join me in welcoming Dr. Falcao.
So good afternoon, everyone. First of all, thank you very much for the organized committee, for the invitation. And it's a really pleasure to be here as an anesthesiologist to talk a little bit about what we can do during the perioperative medicine to help you to enhance recovery of our patients. So those are my disclosures. First of all, we know that when we apply an enhanced recovery protocol in our surgical patients, we can improve a lot the outcomes of those patients. In bariatric surgery especially, we already have meta-analysis with more than 6,000 patients that we can see that ERAS protocol can decrease the length of stay in 1.5 days, decrease the complication 30% without increase readmission or reintervention. And the main pillar behind that calls marginal gain. This is the surgical journey of our patient since the preoperative phase until post-operative phase and post-discharge of our patient. And the concept of marginal gains is to improve even 1% in each step of our patient since the preoperative period until the post-operative period. This is a very powerful concept. If you can improve only 1% of each step of the surgical procedure of our patient, we can improve the outcome of our patient. And this is important because it's not only one intervention that can make a difference of our patient, but it's the bundle of it's the package of the intervention that we can do it. Let's see an example in anesthesia, for instance. The main problem in our clinical practice is we have a lot of variability in our systems. Let's see here, for instance, in the fluid replacement. If you take into account a surgery of 1 hour procedure, the fluid replacement of our patient can vary and 20-fold, depends on the anesthesiology. So we have a huge variability in the assistance of our patients. Again, if you have the surgical line, the surgical journal of our patient since the preoperative period goes through the ward in an OR and in a recovery phase, and we take into account only 3 kinds of specialty. For instance, the nurse or the multidisciplinary team will have many different interventions in the perioperative period. For the anesthesiology, for instance, we have many different interventions, mainly in the intraoperative phase. And the surgeon itself has many other interventions in the perioperative phase. If you put all those interventions together, this happens in the different moments, in the different place, for different professionals with a big problem of communication. So, and we have a big variability in our assistant. This variability is among professionals, and this variability can be with only one professional, but among the different patients. In 2016, we published the official recommendation from IRA Society for the bariatric patients. And FUC is a package. It's a package that involves intervention in a preoperative phase, in an intra-op, and a post-op phase. How can an anesthesiologist can help you to enhance the recovery? And now we have a lot of overlap with the talks before, but we saw very nicely about the preoperative fasting. There is no reason to not allow the patient drink water or clear fluid 2 hours before the surgery, or a light meal 6 hours before the surgery. When you compare obese patients with not obese patients, we don't have a difference in gastric empty. So we need to allow the patient, and the anesthesiologist needs to reinforce that, needs to allow the patient consume to drink a clear fluid 2 hours before the surgery. Another important point, we know that bariatric patient has a high incidence of postoperative nausea and vomiting. Up to 2/3 of the patients can have nausea and vomiting. And 1/3 of those patients can have a severe episode, and 1/4 of the patient can have an episode of vomiting. And the vomiting in the postoperative period, it's a very dangerous thing because it's a Valsalva maneuver, and we increase a lot the intra-abdominal pressure, which is a risk for leaking. So what we can do as anesthesiologists during the surgery, we can start with a multimodal approach to avoid nausea and vomiting in the postoperative period. Another point, usually during the surgery, we use a lot of opioid. And we already know that if we compare an opioid-free anesthesia technique against an opioid-based technique, an opioid-free technique has a low incidence in the nausea and vomiting in the postoperative period. So, as we saw before, it's a good idea to decrease the amount of opioid of those patients. And more than that, we have the opioid paradox. So, if we give a lot of opioids for our patients, these patients can develop hyperalgesia in the postoperative period, and they can have more pain. And if those patients have pain, they cannot do the physiotherapy, they cannot walk and go out of the bed. So the anesthetic protocol in the intraoperative period, we need to decrease the amount of opioid, and we need to start a multimodal approach for this patient who has lower pain after the surgery. This is a very nice study from Bruno and Jean-Paul Millier. It's a retrospective study with more than 9,000 patients that he shows that if we do an opioid-free anesthesia in those patients, we can decrease the postoperative pulmonary complication. As far as we know, our obesity patient has sleep apnea. So the obesity patients, this is a study that we published last year, and we show that our obesity patients can have up to 20% of risk of postoperative pulmonary complication. It's the double, the incidence is twofold than the non-obese patient. So to decrease the postoperative pulmonary complication as well, we need to approach those patients as a lung protective ventilation during the surgery. Regarding the neuromuscular block, this was very nice talk before. We need to keep those patients under a deep relaxation, and if we compare different technique, moderate versus deep neuromuscular block, actually the deep neuromuscular block can promote a better space, and this can help you to decrease the intra-abdominal pressure, and decrease the intra-abdominal pressure can decrease the peritoneal inflammation and can decrease the pain in the postoperative period. So the neuromuscular block the ERAS guideline recommend the deep relaxation and recommend that we need to keep this patient monitored with TOF during the surgery. At the same study from Bruno Yan, with a retrospective analysis of those 9,000 patients, we can see that almost 1/3 was under a deep relaxation and without opioid during the surgery. And as you can see, as far as the anesthesiology can help with the deep relaxation and without using opioid, we can decrease the major complication year by year. So, what is the role of the anesthesiologist in the Enhanced Recovery Program? As said before, we are a team, so we are part of the team. We need to help you and we need to help the team to decrease the variability of the assistance. If you have a big variability, we don't have a good outcomes. Therefore, this is a very nice quote which is published in ERA's website. We need to help you and we need to help the team to put into practice what we already know. Thank you very much.
Excellent talk, and as you can see here, there's a lot of resources between the International Society for Perioperative Care of the Obese Patient as well as ERAS. I'm going to welcome to the podium a friend and colleague, Dr. Guido Mannertz, who probably has the largest experience in the world around enhanced recovery. He has a unique experience of doing this in both Europe as well as the Middle East. So please join me in welcoming Dr. Mannertz.
Thank you, John. Let's start. Well, I'm happy to see still so many people in the audience at this time. I think going to ERAS or bariatric ERAPS is bariatric 2.0. While some people are still learning the procedures and still watching videos, you are here to see the next step in healthcare, which is being working cost efficiently and improving the quality of outcome. And I think we need to do that. There's pressure from the government to lower costs. Obesity is a big problem. Bariatrics is the only solution. So how can we increase bariatrics at lower cost while improving quality and service? And ERAS has been shown to, in other studies and also in bariatrics, to show better outcome, more efficiency, lower costs, less mistakes, and higher volume leads to higher quality. There's a study of Malkside on the enhanced recovery, a meta-analysis, and it shows actually that you can reduce length of stay significantly by fast-track bariatrics without increasing complication rates, looking at major complications, minor complications, and all complication rates. So it's safe to do that. And as John already said, I've experienced in 2 parts of the world. I published from Rotterdam, the previous largest series in the world, and now recently we published from the UAE, 2,000 cases on fast-track bariatrics. And in Rotterdam, we established a fast-track course that many people went to, still running by my colleagues. We're going to set up this same course now in the UAE for people who are interested. And, but then how to start an ERAS program. And so I see it like 3 phases. First phase is, I think, very important, is the preparation of ERAS. What you need to do is set up a team of mandated multidisciplinary champions, at least 4 up to 8. I would not go beyond because then it gets a bit too much. Because, of course, the anesthesiologist and the surgeon isn't there, but very importantly, you need a nurse navigator, or in the US, physician assistant, who is like the oil in the machine and making things work. Very important to include somebody from the management and administration in that group, but also look at people from endocrine, psychology, dietitian. You might even extend to cardiology and pulmonology. And you need to invite these people from the start. I wouldn't advise just to start and later to add them, because then they maybe feel that they were past in it. So I would advise to have them from the start, but have from each team 1 member, not too much because you get too much discussions, and get them mandated. So they will decide for their specialty what protocol is approved. You start to meet on regular basis, and you start writing. And on the internet, like the ERAS Society, you can find all kind of protocols. So you need to write standardized protocols, pathways, order sets, and these things should be based on evidence-based medicine. They should look at cost efficiency, simplification, because the easier you make it, the better people can remember it. Very importantly, break all traditions. Don't try to compromise too much because it will slow you down, and look at how you can improve the service for the patients. Then you need to develop patient information materials, website leaflets, PowerPoint presentations to present to the patients to add the information. This is crucial because the patients are very shortly in the hospital. They don't have much time to see what's going on, what information needs to be spread. So the more you work on this, the more you can pass the information, and adding visual information to that makes them remember it easier, and you can choose the right words if you have like videos. Then you need to create or get a database. These are available, and you need to decide who will put the data in it. It will take about 20 minutes per patient normally, so it's quite a bit of work if you do high volume. The next step, very importantly, present the business plan to the management to get support, especially in the beginning, for time allocation of people and financial support. That's why you need to include them from the start. You need to convince them that this is going to improve quality service and in the end going to make money for the hospital. And the last argument is the one that's most effective, unfortunately. Then what you can do, you can visit EROPS courses. As said, we still have in Rotterdam the course, and we're going to develop it in the UE now. Seeing is believing. We used to have a dinner the evening before, and we would say what the program would be next day of 4 sleeves, 4 bypasses, finished with it 8 hours, lunch in between, and some lectures. Nobody would believe it. But next day when they see it, they believe it, and they start to talk about it. And when you visit with a team, it should not be only the surgeons, it should be the whole team mentioned above. Management, anesthesiologists, surgeon, navigators, and so on. Because then, as said, seeing is believing, and then they will be convinced to get started. Next phase is how to get started. Minimize the participants at the start. If you have 10 anesthesiologists helping you to start the cases, it will never work. Same with OR nurses, minimize it, and then slowly later you can extend. But this is a crucial part to start with. Train the team, OR nurses, ward nurses. We also included an exam to really, and a certificate to make it sort of official. That was quite helpful to get the knowledge there. Set work group meetings to discuss barriers and outcome, very importantly. And you need to do direct feedback as well. That's crucial. We tend to be too nice to each other, not telling what's bothering us. Direct feedback is working best. You can set up a symposium in the hospital to increase the awareness. Very importantly, demand compliance to the protocol. As said, each specialty has decided on their part of the protocol. Once decided, once approved, this is the protocol. There's no other way of doing it. And that's why you need to start with a small team in the beginning and slowly extend. If you start a bariatric fast track, start with similar easy cases. We tend to book only sleeves or only bypasses on a day or only revisions to make it easy and simple for everybody. And especially when you start, this is also important. Very important, finish on time. The OR nurses, everybody wants to go home on time, get their kids from school and so on. If you extend after working hours, it's not going to work. So slowly develop it and get trust. And develop a way of auditing. Phase 3 is to conceal the EROPS program you have and to extend it or expand it. So slowly you enlarge the team, you make it standard practice. Next step, and this we succeeded in Rotterdam, after the bariatrics we started to do this with inguinal hernias, gallbladders. Urology started to do robot prostatectomies, 3 cases a day. Vascular started to do 4 carotics a day, same way. So in this way you make difficult surgery easy surgery by standardization of the whole process, and that's why it's speeding up and the quality goes up. Keep improving by analyzing the data. We all heard about the deeming cycle to keep improving, because at a certain point people think, oh, okay, we're already doing great, maybe greater than others. Why go on? I think this is an ongoing process that keeps everybody sharp. For the management, calculate the profit to sustain the support, because after a while they take it for granted, and you need to calculate how much profit you made to keep their their support. Otherwise, they might pull it out after a while. Boost marketing is also very important to get more patients. Now, in some places, it fails to install ERAS. The choices for that, if you look at literature, is not choosing the right champions. You need to choose people that are influential, that can convince people, that are good communicators, and that like to work together. There should be coherence in the team. Another problem can be lack of time of manpower. Again, as said, calculate it for the management, and you will get it if they see what profit you can make. There can be institutional culture trouble, that there's a resistance to change, poor communication, lack of collaboration. In that situation, you need top-down support. You need strong support of the management, otherwise you will not do it. So if you start, it's nicer to start bottom-up, you know, that it comes from the people doing the work itself. It's more encouraging, but after that point, you need to get the support top-down. That gives clearer ownership, less resistance, less duplication of things, better spread to other surgeries, and more sustainability. As said, compliance to the ERAS protocol is crucial, especially in the post-op phase. This can be a bit more difficult because multiple specialties are involved there, so that's something to look at. Lack of education to the patients and the family. Here it comes back again. For this, we were developing in Rotterdam when I was leaving videos to instruct the patients, both in clinic pre-op, for what's going to happen, during the admission, what's going to happen. People like to see how does the ward look, how does the OR look, they feel more confident, and also post-op their instructions. As said, if you have it in video, it's visual, people remember better. When it's a visual, you can choose the words much better that they understand, and they can look it back if it's on the internet. Another problem can be rapid staff turnover. That's killing if you have that. So hospitals that have rapid staff turnover have more trouble to get ERA started. Use audit, as said, and direct feedback to increase compliance. Just briefly, TWAM results, as briefly mentioned. Just before I came to the UE, I invited the team to come to TWAM, where we were doing on average 8 sleeves or 7 bypasses a day. And they said, well, it's all nice, but you know, we will never get that done to do this a number of cases a day and discharge these patients next day because of cultural differences, and the hospital in UE is a government hospital, so forget it. And the predictions were that it would fail. So what we did, we standardized assets, the complete process, everything is standardized. We discharged all patients, even revisions next day. This is the anesthesiology protocol, completely standardized. We try to, as said, book the same type of surgeries on a day. We start with an easy, fast case, followed by high-risk patients. If you start with a quick case, you get a nice, good start, everybody's happy, and things start smoothly. If you start with a very difficult case, you know, things get delayed, people are doubting if you can finish H1, and maybe it's in difficult cases, they want to put extra lines or whatever, so you get a bad start that's ruining the day. So start with a simple, easy case, followed by the high-risk cases. The reasons to put the high-risk cases in the morning is that you can keep them longer at the recovery, so they don't need to go to the ICU, on which ICU they cannot mobilize properly, so we don't send any patients to the ICU. And we keep them a bit longer at recovery. Then, surgical-wise, as said before, do no further harm, respect anatomy. I aim very much at bloodless surgery. Many surgeons try to get the surgery done and are happy. My goal is to have bloodless surgery because that will lead to faster recovery, and also it will help you to identify complications after surgery much easier if patients either jump out of bed or don't. If they don't, you know that something is wrong. We discussed mobilization and drinking within 2 hours discharge next day, and we published a bit on these logistics with my colleague Stepaniak. This was a day in TWAM in the Middle East, 9 cases done, including bypass. So it is possible in an 8-hour setting in 1 hour. And it is not about the number that can be pushed in a day. It's just to show you that it is possible, and it is not, if the people that have been in Rotterdam on the course, they know there's no rush. It goes all slow and smoothly if you look on the outside, but still all these cases get done. This is by pure standardization of the whole process. Everybody knows what to do, you don't get into trouble, and things run smoothly. This is a study there from Taiwan. So we checked from 2015 to 2017 our primary cases versus the benchmark. And you see with this is in a training setting where I trained UE National, who does more than half the amount of cases. You see the more heavy complications, Clavin Dindu 3 to 5, are 1.1%. If you compare with the benchmark of Malczak in the meta-analysis, that's at 5%. If you look at readmission rate, it's 2.9 versus benchmark 7.5. Reoperation rate 0.7%. Benchmark 2.5. So you get high quality surgery, easily done patients, and you see it in the lower part of the slide. Length of stay when I came was for primary cases 3 days post-op on average. 2017, 1.2 day average length of stay of these patients. So in conclusion, key elements towards ERAS is make a multidisciplinary panel with mandated delegates, describe and standardize all processes, pathways, other sets, and patients' information based on evidence-based medicine, cost efficiency, simplification, service, don't compromise, break tradition, abolish all nonsense, allow only to work according to protocols, so compliance, make all staff and nurses familiar with ERAS, and it also improves the working relation. If everybody knows what to do, the atmosphere is great. And again, people that have been in the course in Rotterdam, they know, it's just like a nice environment. There's no irritation because everybody knows what to do. No unexpected things. You need experienced surgeons using the same technique. As said, avoid bleedings. That will speed up the operation. So it doesn't go faster by faster surgery. It goes faster by standardized surgery and not getting into trouble. As a surgeon, we stay around in the OR. We don't go out for a smoke, and because if they know you're going to be late, everybody's going to be late. Work only with dedicated teams, especially in the beginning. After a while, when you do big volume, more people get used to it, so then it becomes easier, but especially in the beginning. Plan repeated similar procedures, and also very importantly, don't plan any acute surgeries in this bariatric OR. So what we did in Rotterdam, instead of having like 20% acute time in every OR, we would have half an OR empty for acute surgeries, and all our electives were completely filled till 4 o'clock. So nobody will delay because they're afraid to get an acute surgery. If you don't get an acute surgery, everybody will speed up to finish on time. As said, that's very important to finish on time. Get patients well informed and manage expectations up front, very crucial. Create a safety network by protocols, nurse navigators who check on these patients by calling them. Calculate the profit to convince the management to get your support. And another thing, very importantly, this is what I saw actually in the UE. It was very much departmental organized. So the clinic was a surgery wing or a medicine wing. And now in my position as a chair of surgery of the surgery department, we recently changed it to a disease-related units. So we have an obesity, metabolic, bariatric unit. We have a neuroscience unit. We have a thoracic unit. So you work with colleagues that are useful to work with. For me as a bariatric surgeon working next to a vascular surgeon, I mean, we hardly have any patients to talk about. So it's better to be along with your real partners. Thank you very much for your attention.
Well, I appreciate that tremendous overview on how to implement. It's always a lot of work, but I think you've got a step-by-step instruction. We're going to close the session by hearing from some comments from two distinguished panelists, and that's Dr. Anu Wadwa, who is from University of California at San Diego, as well as Bruno Delmons, and I'm going to ask them to both comment on their own personal experiences as well as what was presented today, and we'll start with Dr. Wadwa.
Sure. John, you brought two very important points. One is prehabilitation and the other is opioid use. And I think as anesthesiologists, we see a lot of perioperative depression too in patients, and you have a unique position of having that long prehabilitation period where you see there's a difference of about 6 to 8 weeks between when you see the patient. And I wonder if you actually think that active treatment of depression would actually contribute to that post-operative opioid abuse. And ketamine is a great drug that we have available in the perioperative period that has an effect of depression, and I wonder what your thoughts were about.
I think it's a great topic, and it points out the team aspect to all this with utilizing psychiatry. Many of us are not equipped to deal with depression, so what we do in my practice is we have a Beck Depression Index that acts as a screen, and then we can refer patients. The data about depression and its role for long-term weight loss is a bit mixed. However, it does play a big-time role when it comes to opiate use, so I think that would be a good opportunity.
I think that's an area we really need to probably start thinking about for the long term.
Thank you. And Bruno, your thoughts and comments. We saw your work cited here, and we know you're an expert. Thank you.
I think we have one of the most dedicated anesthesiologists working with us, Professor Jan Mulier, and most of them know them very well. I just have, in the continuation of the previous remark, and back again, there were excellent talks, we have to say. Congratulations for all the presenters, really nice work. But John, what is the percentage now of the bariatric surgery done in the United States when it's done opiate-free? You have any estimate of that?
It's low. It's probably on the order of about 5%. It's just emerging in the United States.
Because we do that now 100%, I mean, which is a huge difference. If you're recalling, you know, that some abuse after the surgery, because you seemingly are very quickly addicted to morphine. I was not aware of that. Jan was saying that. I mean, with all the problems you are encountered now in the US, is there no any, you know, obligation to change that mentality?
Well, that's exactly what we want to do. I think a lot of this that has happened in terms of the problems with the opioid problems in the U.S. have been iatrogenic. You know, they've really occurred as a result of physicians and surgeons. We do have a program we're starting right now in the U.S. called B-Stop, and it's to stop the prescribing of opiates and moving towards opiate-free surgery. And we're certainly going to take the example provided by you here in Europe, because I think there are long-term consequences, not only for...
And you have a good alternative. You have a good alternative, yeah.
There are alternatives. It's not only the overdoses, it's weight gain that happens with opiates too. So, any further comments from...
I have another question, if that can, if I may, just to the presenters referring to inflammation, which I certainly is a very important issue, Dr. Pijols and Dr. Kaczynski as well. I mean, but you didn't give any suggestion regarding medication that can be prescribed. Now, the anti-inflammatory medication, the cortisone, etc. Because we are giving dexamethasone before the surgery, 8 milligrams, 10 milligrams, then they sometimes say it has to be 60 minutes or 90 minutes before. And the anti-inflammatory medication, you know, what is now the rules? Because there was still some association between leaks that have been reported and anti-inflammatory medication. What is now a bit the golden standard in anesthesia regarding getting, by medication, the inflammation down? Can you...
In my clinic, who take care of medications during surgery are more anesthesiologists than the surgeon. So I'm quite classic with this, and you know that after the operations we combine different analgesics, non-opioids. I think that laparoscopic surgery has made a lot of good to the patient, and really it's not very common that the
dexamethasone is not prescribed in your institution, or cortisone?
Anesthesiologists use them during the anesthetic period. Not me as a surgeon after the operation.
Dr. Kaczynski, and
thank you very much for this comment. Indeed, I didn't mention about it, but we do use dexamethasone as a standard.
Okay.
So I should put it in my presentation that also anti-inflammatory drugs like dexamethasone is used. And what also I pointed, intravenous lidocaine, for example, is also now proved to have very good anti-inflammatory effect when administered before the first incision.
Thank you.
So you not only maybe get some effect on the post-op recovery, particularly around nausea and vomiting with Decadron and things like that.
Not only analgesic and anti-inflammatory, but also for nausea and vomiting. It seems that it works pretty well.
Maybe we'll take a couple more comments before we close the session. Maybe Guido and Farouk, you want to maybe have some comments?
Well, just on the opiate-free anesthesiology, I mean, I totally understand the post-op morphine-free, but the idea of ERAS is to have multimodality treatment of pain, nausea, by giving little bits of all kind of medications, adding up to each other without having the side effects. To my feeling, having completely opiate-free is like throwing something away that's very useful. Why not give little bits of something that's very useful? It's like a sort of forbidden use morphine. It makes no sense to me.
I think that's what Luis was saying about the power of incremental gain, right?
The marginal gain, yes. Because I think we need to remind is the concept, because nowadays it's possible to do the opioid-free anesthesia. For instance, my institution in Brazil, we do 100% for bariatric patients, and we learn a lot with Ian. But I think the main important thing is to change the mindset, because the old mindset, opioid was the basis to treat the analgesia. And nowadays, opioid is still in the recipe, but it's no longer the basis. So we use many different other drugs like lidocaine, magnesium sulfate, dexmedetomidine, and others. But if you need it, we use just a little bit of opioids, but not use only as a basis of anesthesia. It should change the mindset.
I agree with Liz here. It's really, as long as we continue to have even a little bit, it doesn't quite go away. So it's important to get that. But the thing is to have it as a standby, not as a routine. I mean, because we're talking protocols. When you introduce something in a protocol, it sticks. But when you have it as something which you can use, if necessary, that's how we did that in our practice. We just said, look, yes, we're not saying no absolutely to morphine and pethidine, but then it requires special effort to do that. In which case, there is a barrier to actually making that happen.
And maybe another last comment, yeah?
Just a quick comment about Jan Mollier. So he's a really good friend of ours, and we've collaborated for many years. And I know he does opioid-free anesthesia intraoperatively, but when you talk to him, he says that, yeah, there are many times that post-op he has to use small doses, but the doses are substantially reduced to almost like 1/10 to 1/20th. So that is the advantage. So yeah, we should not completely ban opioids, because they do have an advantage of both pain relief and euphoria. But we have to minimize the use of it, absolutely.
Bruno, perhaps you'll have the last word for the panel today.
Me as a surgeon, I have to say, not specialized in all those issues. Let's undescribe it. Was a fantastic session, really. In content, I learned a lot, So that was a bit the purpose. But anyway, I was normally to give discussion and comments, but I learned a lot, I'm also in the caloric situation before the preoperative doing physiotherapy, I mean, we're really going to look a bit more in detail, because we're not doing that, and I don't think that it's going to be easy to really install that, but those things are going to be very interesting. I know certainly very well Guido with his program. We do a bit the same, but not as professionalized as Guido doing. So it was very interesting for me, myself, and I hope also for the audience and the people who are still here. Thank you, John.
Well, thank you all. This was a great session. There's real science behind this, and I think the future's bright. So thank you all very much.